Hi there, everyone. Hi. Good evening. It's Fertility Live, and today we are talking to Dr. Jo Pottow. She is from Cape Fertility Clinic, and that is in Claremont, Cape Town. So, hi, Dr. Pottow. I see you are here. So we are going live with your. I'll just send you an invite. So, guys, Joanne Pottow, there we go. A fertility specialist at the Cape Fertility Clinic. So we'll just wait. Thanks, everyone. Hi, how are you?
Fine, and you? Lovely
Good,
to
thank
see
you.
you.
You too. I always love chatting to you because it's always a whole laugh before we actually get onto it
Yeah.
between us. So yeah, I'm very grateful that you could take your time to do this talk. So we originally had Dr. Suleiman Halen, but he had something else come up, but I'm more than happy to have
Oh,
you.
thank
So thank you
you.
very much. Thank you very much for availing yourself. So today's topic we're talking about is what is the most common fertility problems in women? It's a topic, yes, we do it a few times and we do the talks a few times, but I always say that every time we do a talk, there's a whole lot of new women on board that is listening to the talks that doesn't know these things. So, and our main objective always is to educate women, about these things. So that is why we do it all the time. So the first question we've got for you is, first of all, can you please just tell us who you are, where you're from, a little bit more about you?
Sure, sure. So, Leanne, thank you. Firstly, thank you for the invite. It's always so great to spend some time with you and the whole fertility fraternity online. So, my name is Dr. Jo Pottow. I am a reproductive medicine specialist at Cape Fertility Clinic, but it's just Cape Fertility. Our clinic is at next to Kingsbury Hospital in Cape Town. If people are familiar with Cape Town, so in the Claremont area. But we have a lot of international patients and local patients. We are not dictated to by location. We have a lot of Zoom consultations. So for the community at large, if there's any questions or you would like a consultation, there are 5 of us at Cape Fertility, which is wonderful because you will find the doctor that suits you, that you get on with. It's your journey, and it's important to find that right person. So that's where I am, and I'm happy to answer any questions you may have.
Awesome. Okay, so the first question is, what does infertility mean?
So the definition of infertility means a couple that have been actively trying to conceive, and there are time frames to that if you are under 35 years of age, if you have been actively trying to conceive for more than a year and you haven't achieved a pregnancy, it is deemed infertility. If you are over the age of 35, that time frame is cut down to 6 months. So as long as you've been actively trying, and that's, I guess, where the definition gets a little bit tricky, because what does actively trying mean? When is the right time? Have we done all the necessary checks? But that's normally the ballpark of when it's time to step it up and say, okay, I've been trying for this long, it hasn't happened. It does not mean you are infertile, not at all. Sometimes there's lots of little things we just have to see and do and can tweak that can correct it. But that's sort of your time frame. You would leave it at that. But Leanne, you know what it's like. Somebody saying try for a year, don't go and see someone before. A year can feel like forever. So it's also when if it's bothering you, if it's getting you down, if you stressed about it, there's no harm in seeking an opinion. What the person can say is, we've ticked all the checks and balances and everything looks good. Let's try for that certain period and then we'll step it up if we need to.
Okay. So another question is, how common is fertility?
Well, it's very, very common, unfortunately. And I think that's the biggest message, is that there's a lot of people out there. There's a lot of us. We're all there.
Yeah.
It doesn't mean you don't reach your goal. It just means we're
Yeah.
struggling while we're trying to get there. But the statistics, worldwide statistics, you can never say that word, tongue tie at the end of the day. The worldwide statistic is between 1 in 4 and 1 in 6 couples suffer from infertility or require fertility assistance. So
Yes.
if you're sitting at a dinner party and there are 8 people sitting there, there are 4 couples, one of you is struggling, you might just not say it.
Yeah. And it's very important that I ask that question. It's also, like you said, it's to let other women know out there that's watching that it's not only them. So they shouldn't feel alone, that it's like, there's something wrong with me only,
Yes.
So that's why I asked that.
I had a patient this last week who had a miscarriage, unfortunately, and she said she wasn't going to tell anyone. And when I said, but you need the support, it's a good thing to share with your nearest and dearest and the people you trust. And she came back and she said, you won't believe how many people that are so close to me have shared with me, they went through the same thing, and I had no idea. And that's when I said, you see, we've got to demythify this. It's not something that everybody has a baby and it's so easy. It's not.
Yeah.
Everyone's very happy to push the pram down the prom and look at what I've got, when there are a lot of women walking around there, but you don't know what that woman went through to have that baby. You might have been in the exact same position.
Absolutely. Okay, next question is, how long should we try to conceive before we see a doctor? I think we went through that, so I'm just going to skip that one. What are the signs and symptoms of infertility?
So the thing is, sometimes there's none, and that's where the biggest myth comes in, is that it doesn't come with a big heading. It's not like if you've got a cough, oh, you better go and check that out. The problem with infertility is the only way you know if you are fertile is to actually try. Yeah. So if you're not ready for a baby, even if you do extensive testing and all the testing is normal, that doesn't guarantee that you will have a baby when you try. You actually have to just try for those time frames we were talking about. Yeah. But of course there are, and I think that's where it catches a lot of women and men unaware, is they think, well, I come from a big family, my mom never had a problem, she had lots of children, how could I be having this issue? No, we don't know until you try. And and it's also not to scare people that haven't tried and then suddenly thinking, oh, am I going to have a problem? Because we don't know. So I'm not advocating for everyone to try and have a baby if you're not ready, but unfortunately that's the problem. It doesn't come with signs and symptoms. But things that could alert you to, it might not be as easy if a woman doesn't have a regular period. So it does not mean she cannot have a baby at all. But if you don't menstruate, we need to find out why. If it's not regular, which is between 25 and 35 days, your cycle length. If it's not, it comes every 30 days and every 31 days. If there's a little variation, no problem. But if you say, oh no, I have a period and then I skip 3 or 4 months and then I have another one, that could make it more difficult. It's not a sign and symptom of infertility, but it could make it more difficult. Okay.
What are the most common fertility problems in women? What are the most common fertility problems in women?
So I think with fertility, I never leave out the man, because that's the whole thing. There are two key ingredients. Doesn't necessarily have to be gender specific, but we do need a sperm and an egg. And so it's important to make sure that we have sperm, egg, and a normal uterus where this baby can grow. And those are the 3 key ingredients. So when you're doing your checklist of what we're checking, we need to make sure those 3 are all exactly where we would want them to be, in a good space. So if you look at common fertility causes or infertility causes, let's start with the uterus. A woman could have fibroids or any growth. I say to my patients, you can have humps and bumps in your uterus. The uterus is very forgiving. It's a sweet little organ. It'll do as it's told. But we just have to give it the right amount of hormone and nothing inside the cavity. Babies don't like to share. When they come into that uterus, they want that whole space for themselves. So we make sure you can have a fibroid, but if as long as it's not inside the middle of in the cavity causing an issue, that's the thing that would be a common fertility thing. So 1 in 3 women have fibroids, but it doesn't cause infertility. It just depends where it is. But it's a common thing in South Africa. Polyps, blocked tubes. So the problem is if you don't have an open tube, there's nowhere for that baby and sperm to meet. So it's not that you can't have a baby, it's just they can't meet in that tube. We have to help and let them meet somewhere else, and then we'll put the baby in there later. So common is blocked tubes. And I mean, how many of us are walking around, we don't know if our tubes are open or not. You don't. But an ultrasound can alert a doctor and the patient to the fact that there could be a potential issue with that tube. And then, of course, there's tests that we can do. So if you look at uterine pathology, including the tube, those are common. Polyps, blocked tubes. Then we look at the ovary and we look at egg, because that's next on our checklist. Polycystic ovary syndrome, so PCOS, PCOS, people call it all different things. We know it's common and it doesn't cause infertility. It makes falling pregnant so much more difficult. It's not that you don't have eggs, we've got to get those eggs. But that's a lot of what we see is women with PCOS. And then last but not least, endometriosis. Endometriosis is exceptionally common. And if we look at how long it takes to diagnose, it's anywhere between, the average, they state, is 10 to 12 years, which is a long time. And it's because it's misdiagnosed as IBS, oh, you've got a bowel problem, oh, you're lactose intolerant, that's why your bowel's sore. We've normalized period pain. Period pain isn't normal. No woman should suffer. No schoolgirl should go home from school because her periods are too sore. And that should be investigated. So those things are very common and they can all give us problems with fertility. I don't want to say cause infertility. Yeah. So those are the commons.
Okay. Thank you. What are the first tests that need to be done should you be struggling to conceive?
So again, like I say, I'm never going to leave out the sperm factor. And just, I think it's relevant. So many people, when we're saying common fertility causes we spoke about in women, there's just one I wanted to add with men, that a lot goes unknown. In men make sperm every minute. They're not born with their sperm. Women are born with their eggs. We've got this finite amount. But men make it every minute. And the only way you know if it's normal or not is to do a semen analysis. Now, common medications, things like testosterone, that a lot of young guys use because they think it makes them feel better, helps them with gymming, that will stop sperm production. And so those are common things that people are using that they don't necessarily know that it would have a problem with their fertility. So it's one of those just with the male side. So when we look at tests, it goes back to when we're looking from a male factor. A semen analysis is always the first thing. And then for a female patient, to me, there's a little bit, I guess, like us, we're not so straightforward. I mean, it always seems to be black or white. It's a test and it either says we've got sperm or not. With ladies, we need a little bit of this and a little bit of that. So there's not one-off blood test or one-off investigation that should be done. An ultrasound, so a history can give us a lot of information. So I think instead of saying the one test you would do, I would link it and say a consultation with a specialist combined with that ultrasound, which always goes with the consultation because it helps us decide. And then there are a few blood tests to confirm what we think. If we can see your ovary and we can see eggs, we know you've got eggs there. Wonderful, tick. But we want to know what your AMH is maybe, and that would be done with a blood test. But I would never advocate for somebody to go out and do a blood test and then go, oh, I've got a problem, because that's not true.
Okay, we've got a question here, but before we go to that, there's something that a question that I always get from women is, I'm struggling to conceive, and I have done a pap smear, and they're saying everything is fine. You know, what's wrong? So if you could maybe just explain a little bit about a pap smear and the difference between actually doing a test where checking whether or not you've got a fertility issue compared to a pap smear.
Sure. I'm really sorry. I'm sitting in my scrubs. I came out of theatre, but I'm not sitting in my office. So I wish I had my little uterus here to show and demonstrate. But a pap smear is a screening test that we do for all ladies who are sexually active or not. If you've been in the past, there's a risk that you have HPV, which is human papillomavirus. So if you had to look at the uterus, if I had to be the uterus, and this is the uterus, this is where the baby would grow, and this is the lining we build and bleed off. It's the mouth of the womb, the cervix, that these cells can become infected with HPV. There are also other causes and can cause these cells to change over time, and they can become cervical cancer. So that's the mouth of the womb. That's got very little to do with fertility. Of course, if you've got cervical cancer or you've got an abnormal pap smear, that's very important in our workup, because the last thing we want to do is to help you conceive and then we find out, oh, there's a problem with the cervix. So a pap smear is not checking anything with fertility. It's an excellent general health screening tool that is good for women's health because it's so easy to treat. If we find funny early cells, very quick to treat, and that doesn't become cancer. So we're trying to prevent cancer. Nothing to do, unfortunately or fortunately, I don't know which way you look at it, but a pap smear does not mean you've checked anything with fertility.
Thank you very much for explaining that.
Use my hand, my little making of a uterus. I don't know. People are probably thinking, what is she doing? But anyway.
Thank you. Okay, so our last thing is, how do they get hold of you at Cape Fertility?
Okay, so multiple ways. You can phone. Our number is 674-2088, and that is on the Cape Town dining code 021. You can phone. The secretaries will put you through with the greatest of pleasure and also help you set up an appointment. You can go to the Cape Fertility website, which is www.capefertility.co.za. And all of us doctors, all 5 of us, are there at the bottom, all our photos. You can click on there and you can communicate directly with me. An email will come through. I'm happy to answer any questions anyone has. And if you would like to come for a consultation, you can also let me know.
Perfect. Then if you don't mind, if we just ask one or two questions that has come through. Is there any information, one of the ladies asked, is there any information on the Dutch test?
The Dutch test, in terms of, sorry, just to confirm, is that where you are talking about the, there is a particular algorithm that works out and calculates your risk of, or the chances of conception? Is that what she is making reference to?
I have no idea. I just thought maybe I've never heard of it.
Okay.
So that's why. Okay, so maybe what we should do is we could actually just send you an email. Maybe she can just pop you an email, and explain a bit more to you
Sure,
in
I
that
can talk
email.
about that if it's that what she's making reference to. It's a wonderful tool that is used, but you have to have investigations already. So you would have a semen analysis, you'd have the patient's history. So you need age, time of trying to conceive, plus some of the other factors that you have to put into this algorithm, and it gives you the chance of conception. It's based on, it's a nice figure, and it's a nice tool to help somebody see just how grave the situation is, or how they can, like, don't worry, we've got time. But if you actually look at the things that are heavily weighted in that algorithm, it's female age. Why? Because we're born with our eggs. The older we are, the less likely they are to work for us normally and to find a normal one. And then it's also heavily weighted with sperm motility, which makes sense. If the sperm can't swim, how does it get up to the egg? Yeah. So if that's the system she's talking about, it's a great algorithm, it's helpful, but it has to be interpreted, if that makes sense.
Okay, perfect. We've got one more. It says, I suffer from severe period pains where every month I'm off on sick leave for 2 days.
And that's not normal. And that's the problem, is that women say, you know, my mother had terrible period pain and so did my grandmother. So we've all just got terrible period pain. It's not normal. A woman should not have excruciating pain that she cannot function. Yes, it's mildly uncomfortable. It's a little bit of a discomfort, but there is nothing that should keep somebody from working and doing your daily activities. So when somebody says that to me, big alarm bells go off in my head, that we've got to look and see, do you have endometriosis? There will be other subtle signs, there's subtle signs on the ultrasound. And the new guidelines now say you don't need to do a laparoscopy to diagnose it. You don't need to go and say, aha, I've seen it there. You can actually put somebody on an oral contraceptive and it'll control their periods, it thins the lining, and it's used as a treatment to see if we get some improvement. So somebody who has such severe period pains, the oral contraceptive is one treatment. There's another registered treatment that we can use and if that clears up your pain and you go, my goodness, I feel like a new person. Some of my patients call it their happy pills because they're like, it takes all my pain away. I feel like a normal person. You've got endometriosis. So I'm not saying just because you have it, you've got endometriosis. You might have a terrible big fibroid sitting there and then your uterus is contracting. I would suggest you see somebody, they take a history, an examination, and then come to the bottom of that, because you should not need to take time off work from period pain.
Okay. Great, thanks. And then there's one last question I'm going to ask. I think we've got a few minutes left. Is it common to have high blood pressure readings during menses, and what is the possible cause?
So the thing is, pain in itself can cause your blood pressure to go up. So if you have excruciating pain, there may be, you know, but then I think it would have to be quite bad to cause you to have an increase in blood pressure. But blood pressure, we've got ranges. You know, when we say the upper limit of normal is 140/90, we know we would like you sitting around 120/80. And they've even revised the guidelines to say a little bit less even, you know, 110/70, somewhere around there. It shouldn't be enough. A period variation should never be enough to make your blood pressure shoot up that it becomes abnormal. So there could be slight variations, but you should never be losing so much blood that it drops your blood pressure. They've worked out, and I think it must have not been a lady that did that research, that said you only lose 80 mils, 80, your whole 5 days of bleeding. And every person I told that said, well, that person never had a proper period then, because it always seems like a lot more. But you're not meant to lose a lot of blood. So it's only if you've got some abnormalities that you would have changes in the blood pressure, like tons of blood loss will drop your blood pressure. Severe pain might increase it, but it's not a known phenomenon that in your period you're going to have increased or decreased.
Okay, awesome. Thank you very much for joining us this evening. I really appreciate you taking the time out. Even though you're sitting in your scrubs, you still took the time to come and see us. Thank you very much.
Thank you. And thank you so much for everything you do for everybody out there, that they've got somewhere and someone to talk to. And thank you for organizing these. Without you, nobody would be informed. So thank you.
Thank you very much. I really appreciate that. Have a great evening. Thanks, everybody.
Bye-bye.
Bye.